Okay, welcome and thank you for joining us today. For those of you who haven't met me yet, I'm Bob Harris, one of the newer body imagers at USC, and I'm proud and honored to introduce Dr. Dan Mollura to you today. Dan is the founder and CEO of RAD-AID International, an organization many of you may have heard of and may have worked with before, but it's the premier nonprofit organization for increasing health and radiology medical care to underserved and resource-poor communities, both in the US and abroad. Dr. Mollura received his medical degree from Johns Hopkins University and followed up with training in resident diagnostic radiology residency and fellowship at Johns Hopkins Hospital. Based on his background as a Goldman Sachs financial analyst and prior founding of 3 other successful startups in the media, technology, and public sectors, Dr. Mollura then founded and led RAD-AID over 12 years ago to become a global nonprofit organization with nearly 14,000 members, serving over 80 hospitals in 35 countries. In addition to his 10 years at Johns Hopkins, Dr. Mollura served for 10 years on the radiology clinical faculty and research faculty of National Institutes of Health in Bethesda, Maryland. On a more personal level, I've gotten to know Dan over the last year or so and been very impressed and motivated because he personally embodies tireless dedication and humility in his global radiology work. I welcome you, Dan, and look forward to your talk.
Thank you, Bob. And thank you everyone for coming together. It's great to be here with you. I wish I could be there in person with you. Hopefully when all of the pandemic is over, I'll be able to visit you and see you all in person. But Bob, thank you for that very nice introduction. I also want to thank Dr. Ryu, who is part of this invitation. We had communicated a lot through the course of the year, and that's part of what brought us all together here. So for today's presentation, I'll be talking to you about RAD-AID, bringing radiology to the underserved. And we have a lot of fun things to go over, so we'll get started right now. So what's in this presentation? So first of all, we're going to talk about the scale of the problem, the global health and radiology disparities question. You know, what is global health? What is radiology disparities? And what does that mean for us? The second thing will be RAD-AID's method. So this presentation is designed to give you the tools in how to think about disparities and radiology's role in global health. And then I'll give you some examples of how RAD-AID uses this method to make change in areas of the world that don't have radiology. And then we'll look at the range of applicability to that, because whenever you hear about a method, you always want to know, well, how well will it apply to this situation or that situation, or will it apply to everything that I encounter in a global health environment? So we'll talk a little bit about that. The fifth thing will be the impact of COVID-19. This has been a very difficult year for the whole world. And there's a lot of interesting aspects to COVID-19 in global health and radiology that we can talk about specifically with regard to how RAD-AID has handled this year and how we hope to get beyond COVID-19 then in the future. Then the next thing will be about race relations in healthcare disparities. Most people think about global health as a very poverty-driven type of discipline, that the absence of resources is often assumed to be mainly because of economics. But it turns out that global health is more than just poverty. It's also race relations. It's also in social justice concerns and how different communities, nations, ethnic groups, et cetera, all interface with each other. So we'll talk a bit about race relations in healthcare disparities. And then a presentation on anything in radiology these days wouldn't be complete without addressing artificial intelligence, particularly in global health. What is the role for AI in RAD-AID's work and in global health in general? So let's begin by talking about the essence of the problem. When I got started with this, I was just starting my fellowship at Johns Hopkins. And so I was a newly minted radiologist, so to speak, right? And outcomes statistic like this one that was published by the WHO, about 4 to 5 billion people have no access to radiology. Now that was profound to me because here I was, the newly minted radiologist, now in my fellowship year, and thinking, how can it be that almost 2/3 of the world don't have access to all of this that I do every single day. And then the impact of that was tremendous because if you think about it, imaging is a part of nearly every part of healthcare decision making. So whether it was ultrasound for maternal infant health, or mammography for breast cancer screening, or CT for cancer staging and cardiovascular, et cetera, you know the list because you're all in the radiology community. But to the public health side of the world, they never really thought, well, what does happen when imaging is absent? So if you look at some specific examples, so here's Tanzania, has 58 radiologists for 56 million people. Now I'm willing to bet that at USC, you've got more than that in a single building. And it's profound what having 58 radiologists for 56 million people really means. A country of this size with this population, if it were at the US level of radiologist accessibility, should have between 4,000 and 5,000 radiologists. Instead, they have 58. Another example is Kenya. So Kenya has fewer than 10 IR attendings for 50 million people. So 50 million people would be like all the West Coast of the United States. Can you imagine 10 IR attendings covering the entire West Coast of the US? Or 3 breast radiologists in Kenya for 4 to 5 million women every year that need annual mammography. The population of Kenya is closer to 50 million, but the thing is the women in need of screening would be around 4.5 million. There's only 3 breast imagers that are fellowship trained in the country. So how do you deal with these kinds of shortages? Well, that's the personnel side. So let's look at the equipment side. So low-income countries have about 1 CT scanner per 1.7 million people, versus in high-income countries, 1 CT scanner for 25,000 people. So the magnitude of difference between high and low-income countries is pretty massive. And then if you look at this, it's the same levels of disparity when you think of upper middle income and lower middle income countries. So that's how I got started. It was 2008, and there I was coming into fellowship, and I thought I really want to start an organization that might be able to impact this deep problem. And so the mission was very simple: increase and improve radiology in underserved and resource-poor regions of the world. Well, the first question whenever you're going to do something like that is, well, what are you going to do that's possibly different than what everyone else is doing? There's plenty of nonprofits throughout health, as well as in the radiology space. So what would make RAD-AID different? Well, as Bob mentioned, I came from a background that was Wall Street before I changed over to become a doctor. And one of the things that we always did in the finance and economics world was due diligence. You have to prepare yourself ahead of time to plan a project and plan a program in a way that really predicts what your impact is going to be. Well, what we found in 2008 and 2009 as RAD-AID was getting started is that there were a lot of well-meaning charities and well-intended companies even that would donate equipment without any clue as to how that equipment was going to be used, or who was there to actually use it, or what infrastructure was available to support it. So what happened is that there was a lot of wasted resources being donated into low and middle income countries as a result. So what we did was we came up with a concept called radiology readiness, which asks the question, is a place ready for radiology? And in order to look at readiness, what you have to look at is not what they need, which is often everything, but instead, what are they ready for? And asking a question that flips it on its head and looks at what a place is ready for asks, well, what do you already have that's existing at your site? And then what are your goals? And then let's find the high yield gaps that we can fill. And that's where the radiology readiness assessment came from. So this is the components of that assessment. And you'll notice if you look at this screen, it's got a lot of pieces in here that actually have very little directly to do with radiology. Because as you all know, as radiology professionals yourselves, you know that a lot goes into radiology that's not directly integral to what we do, but is connected to it, such as clinical testing, or human resources, or IT, patient financial issues like insurance. So these are the different areas of the hospital and the enterprise that affects how well radiology will work for that health institution. So that's essentially how RAD-AID works. It starts off with this radiology readiness assessment, looking comprehensively at what an institution already has, asking the question, are they ready for more radiology? And how would they use that radiology to make a difference in their patients' lives? And then use that assessment to collaboratively plan a program with the receiving hospital, then implement, and then do a lot of training back and forth. So we train them on how to sustain their program, but a RAD-AID volunteer also receives training from that hospital in the local practice patterns, in the institutional features, and in the cultural items that will be part of, how to make the program effective. So it's a very reciprocal training experience. And then we analyze how things went, what went right, what went wrong. And then we either go through the cycle again, or we repeat the assessment again, or we can continue working on aspects that we found in the initial assessment. So if there's one slide that has the biggest bang for the buck in this presentation, it's right here, because this is how every single RAD-AID program works. So that's how we grew to where we are now, starting off in 2008, 2009 with just a few people, and now almost 14,000, which you see here. Volunteers getting involved and doing projects in RAD-AID programs in the hospital, shoulder to shoulder, working with the practitioners that are there, and also remotely trying to support them one-on-one, group to group, facilitating this kind of development. So now we're also in 38 countries and 83 hospitals. So this is a map of all the locations throughout the world, and we continue to add more as more of them come to RAD-AID saying, let's start with a radiology readiness assessment and go through that cycle together. So the volunteers themselves come from about 114 countries. And if you look at the composition, we're very different from what you'd expect of a professional society. So we are a charitable organization. So as a charity, we are a mixed group, technologists, radiologists, sonographers, IT specialists, because the idea is that every team has these different components, just like you would in your own hospital. MDs don't do things by themselves. We do them in teams with nurses, technologists, IT, et cetera. So RAD-AID is constructed exactly the same way, with the same multidisciplinary format that you would expect in your own hospital. Now, the volunteers themselves are also from all over 114 countries. So about a half are in the US, 8% in Canada, 8% UK, 6% continental Europe and Australia. And then about a quarter of RAD-AID is in the low and middle income countries themselves, which reinforces the fact that our teams are very much internationalized. Instead of us thinking of a nonprofit as something in a high income country just giving to a low income country, this is a very reciprocal community structure. And that's how RAD-AID has been designed from the very beginning and has evolved. So now let's look at some examples of how that radiology readiness paradigm really plays out. What does it look like when you get off that airplane or you show up there, or even if you're doing things remotely, what ends up happening as you start to interface with a low resource hospital? So let's take this example. This is in Ghana. This is a hospital called Korlebu Teaching Hospital in Accra. And here's the outside of that radiology department. So you walk in the door and it's 2012, and this is what you find. It's pretty overwhelming. If you didn't have a method to fall back onto and use for assessing this type of environment, well, you'd feel pretty overwhelmed and not even sure how to accomplish anything. So as you're walking through this hospital, you start to see rooms like this one, and this one, and this one. So already you're probably still feeling pretty overwhelmed. And that's why the radiology readiness assessment is so important, because you have to go back to a method. You have to say, okay, I know that what I'm seeing is really hard, but let's just start at question number one. Let's start with working with the teams that are there and exchanging information about what all this means. Well, it turns out that when we did this radiology readiness assessment, we also found out that the Ministry of Health of Ghana was in the process of purchasing and delivering new equipment. So you think, oh, well, this is good. That solves part of the problem, maybe even all of the problem. But the radiology readiness assessment also showed that this new equipment was coming with no DICOM licenses, which meant it wasn't going to be able to send images to digital workstations. And there was no PACS, there was no IT. So even though the equipment was capable of doing digital imaging, it was not going to have any of the onboard functionalities for making that possibility real. So RADI went ahead and, in collaboration with Corlebu, signed an MOU, Memorandum of Understanding, and did a grant donation of the PACS to supplement that incoming equipment so that we could harmonize their plan with an additional plan that would further leverage the resources they had. And this is the impact that came out of this. In 2012, going from this, by 2013, looked like this. And then by 2016, we did another upgrade as well. We then integrated that with the rest of the support that we were giving to Corlebu, such as this session on breast imaging, or this session on neuroimaging, and this session on IR. So the point being, before I go on to the next country, is that you're looking at a location and it looks very overwhelming, and the scarcity and disorganization of it all overwhelms the senses. But you as a radiologist have so much capability that just by doing a readiness assessment and then a good relationship building with the hospital can come up with a collaborative plan that leads to these kinds of outcomes. So let's look at another example, because now the next question that always comes out of that is, well, is that what you do everywhere, RAD-AID? Is you just show up and give somebody a PACS? Is it a cookie cutter kind of thing where everybody gets the same, hamburger and French fries, or is it a little more tailored than that? Well, let's look at another example. Here's a children's hospital in 2015. Now, unlike Corlebu, which had been around for a very long time in Ghana, this was a brand new hospital, Lao Friends Hospital for Children. And they approached us saying, could you do a radiology readiness assessment in our institution? Because we're trying to develop radiology for our new pediatrics hospital. So we sent a team there. And in contrast to the pictures I showed you of Corlebu, what we saw in Lao Friends Hospital for Children was that the radiology department was an empty room, a concrete room with nothing in it. There was no equipment, there was no radiologist, there was no tech, virtually empty. But it had all the other parts of the hospital going. There was a NICU, there were pediatricians, but there was no radiology at all. So we went to work building up an entirely new radiology department, donated an ultrasound unit, working on their x-ray, donating a PACS, which I'll show you, implementing safety and imaging protocols, and from the ground up, starting this radiology department. And this is what you started to see over time in Lao Friends Hospital for Children. We donated this ultrasound unit, taught this local staff to do imaging. Here you might even notice this is an intussusception by ultrasound on a handheld. And then when they were ready, after they had been doing this a few years, we instituted a PACS in 2019. And then by 2018 and 19 also, an adjacent hospital got a CT scanner that they were willing to share with the children's hospital if we could then bridge the PACS together with this adjacent hospital. And it led to the first CT scan being done in this partner hospital for the children that would come over from LFHC. So the point being, I've just showed you two hospitals, very, very different, but the method is the same. You approach it exactly the same way with a radiology readiness assessment, but instead of having every solution look the same, it turns out to be very different because you're tailoring it to the conditions that are inside that facility. And as you can see, in the case of Lao Friends, we had to build a radiology department from scratch. But at Corlebu, where there was already staff and equipment and other things happening, we were able to plug in the key hole in the missing packs by providing the other resources. Well, let's look at another country, Guyana. So this is on the northern coast of South America. We did the radiology readiness there in 2015. And here's a country of about 750,000 people, had a lot of other issues like scarce CT and no health IT, suboptimal ultrasound. But here was the key issue. There were no radiologists being trained anywhere in the country. There was no residency. There was no way for a doctor in Guyana to even become a radiologist, which meant you had a permanent scarcity problem that would permanently limit the development of imaging in the country. So in this case, our assessment said, let's start a residency so that Guyana gets its own in-country training for future imagers. Now, this is very different again from Corlebu. Corlebu Teaching Hospital in Ghana had a residency, still does, has a residency, right? So we're going to start a residency from scratch. How do we do that? Well, one of the things is we also have to address access to hardware, so CT. So we started to donate CT. And here that is, rolling in the box in 2017 and fully operationalizing it by 2020. And here's the announcement even this past year, CT scans now becoming available at New Amsterdam Hospital. This was published by a newspaper in Guyana. And these are the individuals that we've been working with to make that possible. Now, here's the best part, right? Many of you are probably residents. These are all the new residents in Guyana that are now becoming radiologists, where that was a dream impossible just a few years ago. And they took this picture together, they created this banner, they sent me this picture, and you can imagine how it made me feel to see all these people basically get their dreams come true. And this was not possible before, and it was just such a joy to see people becoming radiologists in Guyana to perpetuate this capacity building. Here's some more pictures of them at work. At the same hospital for this residency, couldn't stop there with just the residency and CT. We did donate a PACS. Here's the before picture of the reading room, which then became this very well-organized advanced reading room for training residents in Guyana. So now let's look at another country as an example, Tanzania. I know that some of you are working with Bob, possibly for the RAD-AID USC chapter to contribute to Tanzania. So if you look at Tanzania, look at the gaps in access to personnel. Radiologists, 1 per almost 2 million people. So I told you before, there's about 58 radiologists in the whole country. Radiographers, 1 per 116,000 versus 1 per 2,000 here in the US. So there's about 100-fold, 150-fold difference in access to key personnel. So we sent teams in 2015 to Tanzania, and we found that this was the consistent outcome of the radiology readiness assessments. There were institutions that had equipment, but the access to personnel was a dramatic gap. We had to do more to train individuals that were doing radiology in Tanzania. So RAD-AID started programs in Dar es Salaam, Moshi, Arusha, and in a little bit in Mwanza. This is all in the northern areas of Tanzania. And here's one of our volunteers training. Even this was back in January of this year, doing technologist training. Here's more in Moshi. This is a KCMC where there is a residency. Here are the lists of the hospitals: Aga Khan, Muhimbili, NSK, KCMC. So you can see this is a very large multi-institutional effort that RAD-AID has in Tanzania. Here's a picture of our Chief Operating Officer, Anne-Marie Lugasi, who was there in Tanzania personally to do a lot of teaching. Along with that was safety training that goes with every radiology department. So here's two nurse volunteers from RAD-AID teaching how to do safety and infection control and patient management in the radiology division. And here's some more pictures of those safety trainings. And here's some more of those. So if we summarize the radiology readiness approach, the idea here is that you're looking at each institution, looking at what they already have, what they're ready for, and then offering a tailored solution. And by using the similar method each time, what you're doing is you're not reinventing the wheel of the method every time, but what you're instead doing is you're following the efficiencies of an established method, but coming up with a very unique solution that is going to be different because it needs to be locally tailored to the location. So in Laos, where they had a children's hospital, but no radiology department, we built the radiology department. In Ghana, where they had hardware and personnel, but no IT, we gave them IT. In Guyana, where they had an advanced hospital with no radiology education, we started a residency. And in Tanzania, equipment with vast personnel gaps and shortages, we have multi-institutional education. So this really does work for every context. If you look at a bunch of mobile programs that RAD-AID works on, here's an example of a mobile program in Morocco. This is the RAD-AID volunteers using a handheld on this mobile. And you can see the amazing camaraderie that comes out of these programs. This is obviously pre-COVID, but the thing is, here they are in front of that van taking a great picture with locals that are there. Here's another mobile program, RAD-AID India. This is for women's health, breast cancer screening, cervical cancer screening, and osteoporosis, always out of the radiology readiness assessments, looking at marginalized populations that can't access tertiary care. So here's that model in India. And again, more trainings, more workflow management in India. Even inside the United States, same exact approach, radiology readiness assessments. Here's the teams that went there. And in this case, this is a mobile as well as an open air free clinic. You can see here a number of tents, and here they are inside the tents. So even if you're in a 2,000 bed tertiary care hospital or inside of a tent, it's always the same approach, that readiness strategy that leverages what they have in order to produce new outcomes by just filling in targeted gaps. Even a refugee camp. Here's another example. This is from RAD-AID Jordan. This is the Zatari refugee camp where you have about 80,000 inhabitants. And this is the head of that program and led teams over to Jordan to help a refugee camp. So the point is that even across these contexts, you end up seeing how the method really does apply. Here's the example from RAD-AID Rwanda. I mention this also because Bob has a lot of experience in Rwanda that he can help USC develop with RAD-AID. A number of hospitals that have partnered with us, such as Chuck University Teaching Hospital of Kigali and Rwanda Military, again, supporting residency programs there. And here are some great pictures of Bob when he was working there as a volunteer. And here's some more. So now the question is, well, what about COVID-19? Did COVID-19 change all this? What happened as a result of this year? Did it end it? Did it change it? You know, what's the impact? Because this has been a big deal to have a pandemic that was so disruptive to international travel that how do you operate if you're a global health organization? So the answer is it's the same method. It's the same exact radiology readiness assessment strategy that starts out with this and then goes through the cycle. But the difference is readiness for radiology has changed as a result of COVID-19. Well, why is that? Well, it turns out that a lot of these hospitals have scarce ICUs or few or no ventilators or can't use a dedicated room for a COVID patient for CT or X-ray, or may not even have PPE or available testing. Many of the countries RAD-AID was serving in had strict stay-at-home orders, interrupted radiology residencies. So some of the residencies had to stop having their residents come in. And some hospitals in low and middle income countries were converted into complete COVID centers. So what that does is it changes the readiness construct. So you can see here, these are those residents I showed you from Guyana. They still had to practice and learn their safety measures, but now they're all learning and using PPE. We also had to really lean in and change the way we would mentor and support these hospitals through remote strategies such as web-based lectures, case consultations, a learning center, And RAD-AID is an affiliate of the WHO, so we had an advisory role to fill. So here are some examples, and you remember some of those other pictures that have everybody hugging and taking close pictures. Well, we had to change all that this year. Here they are in PPE, so you can notice this picture in Ghana, a lot of social distancing in that picture. Or in Malawi, we donated and distributed this PPE. Or here's a Zoom photo from the teaching of the residents. So it has to continue, even though we now have to consider different circumstances for what radiology readiness now means, because they have to account for the fact, well, COVID-19 is going to impact that. So what does some of this remote support look like? Well, here's an example from the RAD-AID interventional radiology program. We're using a simulator that usually we take into the country. Here's the simulator. But now we're doing remote demonstrations using a simulator. And this is important because if this person is in New York, and here is the demonstration of the case and demonstrating that using real-time simulation. So in this particular case of RAD-AID Kenya, where we laid the groundwork for a new fellowship program there, we launched the fellowship there this year remotely using this format, as you see here. The curriculum was formed and developed, and we have now a partnership with the University of Nairobi to run an IR fellowship in Kenya. And even though we had to remotely support this fellowship, it is still ongoing, and we're still able to do it through remote lectures and remote demonstrations. Malawi, same case, same scenario, donations of PPE. We even gave them a grant to put in more internet services for their hospital so that they could better connect to RAD-AID instructors. I mean, what good is web-based teaching, right, if you don't have access to the internet? This hospital didn't have access that was strong enough for Zoom and other ways of presenting live lectures. So we gave them the grant in order to make that happen. So here's some more examples of those online teaching in Bangladesh, Tanzania, Liberia, Ethiopia. Really fantastic engagement that ended up occurring as a result of these forms of outreach. In fact, in many ways, it actually increased our reach. Because in an average visit to a location, if you were teaching 20 or 30 people, that would be considered, pretty good. But in this particular case, in Bangladesh, for example, about 100 people were coming to these sessions. So there actually is an opportunity in some of the online formats that is leading more people to engage RAD-AID than ever before. But what in the long run, we can then integrate that back when we do on-site visits in the future, because we can do on-site plus online learning together. Here's another example from those residents I showed you before. Now we continue to do the infrastructure support. So even though COVID-19 may have interrupted things, we completed a CT suite build in Gonaives, Haiti. And we installed 2 new CT scanners in New Amsterdam and Bartica hospitals. And that's one of the articles I showed you before. So you might say, well, how did you do this? Well, remember the residents that were trained in Guyana, they were actually able to help with the installations of CT and do some of the protocol developments and safety measures and some of the initial implementations because they were already in country. So some of the fact that RAD-AID's programs has in-country partners is enabling infrastructure to support to continue, even if we're not able to send a team into the country itself. So now, I've told you about COVID-19. That's been a big deal in terms of how it impacted this year. But there is something else that really happened this year that has changed the dynamics of health really for a long, long time. And that was when the murder of George Floyd occurred. As you probably remember, that was in May. It created this real sense of urgency and social tension about what do we do about underlying racism that is in the community, the culture, and systemically. And is this part of healthcare disparity? Well, this was occurring in May as we were also dealing with COVID-19. So you can imagine this is a convergent trend that for global health has tremendous impact. So you might think, well, wasn't that just the US? Well, it turns out that a lot of the protests and a lot of the response that came from those incidents spread throughout the world. This is a map showing all the protests throughout the world that were driving at the issue of increasing visibility of the role of race relations in social justice. So during this year, RAD-AID implemented what we called the well-wish wall. This is people in RAD-AID were able to post messages and take a photo of themselves saying well-wish wall, along with a quote giving people encouragement and strength through such a difficult year. So here are these pictures that people were posting from RAD-AID to reach out across so many barriers during the year. And these are the types of quotes that ended up on the well-wish wall, like, "We are all in this together, love from New Zealand," or "Be yourself and encourage, tough times never last," from Grenada. Or here in Nairobi, "For those in the front line fighting the pandemic, you have all shown the world what true selflessness and love for humanity is." So we were already trying to bridge so many of the gaps that exist between cultures, institutions, and countries. But now we have to do even more, because if you think about it, racism is implicit and it's a part of healthcare disparity. So if you look at this article, Systemic Racism and Mammogram Guidelines, this came out of a Council on Foreign Relations and the Journal of Breast Imaging, where there was a thought that, hey, maybe the mammography screening criteria don't really account for the fact that Black women get cancers earlier that are more aggressive, and as a result, may be more likely to die from breast cancer. Well, if you look state by state, the mortality rate from breast cancer between Blacks and whites is actually starkly different. So if you look at Louisiana, 1.66 is the ratio between Black mortality rates and white mortality rates from breast cancer. You look at where I am, I'm in the Washington, D.C. area, it's about 50% higher mortality rates. So if you look state by state, you start to realize, hey, there's a big difference in mortality rates between Blacks and whites. Same went on for COVID-19. As you probably have seen, the literature has borne this out. Here's a paper showing Black and Hispanic Latino having much higher mortality rates from COVID. Here's the example of cervical cancer, an article in Human Rights Watch, Alabama's failure to prevent cervical cancer death in the Black Belt. Well, the Black Belt is that region of the South that goes from Texas all the way up to Virginia. It's called that by historians and political analysts because it has a very high concentration of African Americans, and they've noticed very large differences in mortality rates from cervical cancer in these regions. Well, RAD-AID has a program in Alabama, and if we talk about this for a second, it starts to highlight what the role of race relations really is in a global health outreach effort. So here's RAD-AID Alabama. Our team went from the University of Alabama RAD-AID chapter. They were working on ultrasound trainings and outreach. But here's an interesting photo that this team sent to me when they were there, and they took a picture of themselves on the Edmund Pettus Bridge. Now, for those who are not familiar with the history, the Edmund Pettus Bridge is a historical landmark for civil rights. This is where a lot of activity happened in the 1960s. So why is this picture relevant? Well, our RAD-AID team saw themselves as part of this history. It connected their experience in Alabama in 2019 back to the Edmund Pettus Bridge in the 1960s. And that's very much at the essence of what RAD-AID is doing. It's connecting all the different aspects of why healthcare outcomes are different for different parts of the world, different ethnicities, different races, and then feeling it as it comes back to them in their own experience as a radiologist or as a technologist. So we started this year the USA Women's Health Access Initiative. This is to address racial disparities, particularly among breast cancer and cervical cancer. We have sites in development across the US. Our partner is the Black Women's Health Imperative. This is supported and funded by Hologic. And here's where the sites are now starting to pop up for RAD-AID USA, New York, Washington, D.C., North Carolina. There's Birmingham, but there's also going to be Georgia and Mississippi. Here's a picture of me and a group of people with the Washington, D.C. program. And this is connected to the chapters because here's the chapters throughout the United States who will be able to participate in an initiative like this one to increase access for care among women of color throughout the United States. Specifically, the example in DC, this is Ward 7 and 8. This is DC, the White House in the middle. And, you notice that Ward 7 and 8 has some of the highest breast cancer mortality rates in the country, and yet 18% living below poverty level. So what do we have to do to approach this? Well, here's a mobile strategy that we're using in this location. And we're also emphasizing the build out of patient navigation. So this is an important part of global health outreach. Most of us think about radiology from the standpoint of interpreting the image. But when you're reaching out to underserved populations, you have to think about, well, how is the patient going to find you? Is the patient going to come for a mammogram or other forms of imaging? How will that patient then know to follow up and receive subsequent necessary care? So patient navigation is a part of helping patients to navigate not only radiology, but the rest of the healthcare infrastructure. So for every program RAD-AID has, we're developing a navigation strategy. So here are the map examples. You look here, this is our program in Phoenix, Arizona, the program in Seattle, Washington, Denver, and the Bronx, Manhattan, New York, looking at how patients who come from underserved areas or where there's higher mortality rates among women of color, how can we better support them to find their screening and receive their downstream care? Now, this all plugs back into RAD-AID's global health footprint, because here's that team, RAD-AID Haiti, teaching clinical breast health. Or here's the team in Guyana teaching professionals how to palpate for lesions, or linking that to the implementation of a PACS to read mammography, or this community health outreach program that we sponsored and supported in Nicaragua, and again, that photo from DC. Now, again, remember, it all comes back to that radiology readiness assessment, because each of these sites is designed around those principles. What are they ready for? What are the gaps, and how do we fill in those gaps? And that's essentially what you see here. So we're able to link the global health experience with the local health experience. So last on this presentation is, what about AI, right? You can't have a radiology presentation without talking about AI. Does it have a role? What does RAD-AID do about AI? Well, RAD-AID offers a three-pronged approach for increasing AI for resource-poor hospitals. I told you before about a number of facilities where RAD-AID has donated and implemented PACS. And PACS might very well be the first step for a lot of low-resource hospitals to eventually use AI. Because can you imagine, if you didn't have a PACS, what format would you then use for even using AI or thinking about AI? Well, the other thing about AI is that, well, if you deliver AI to a place that doesn't have radiologists or technologists, for example, who could supervise those outputs of the AI platform, how are they going to know to trust what AI is telling them? And if you're dealing with an environment where there's so few personnel, or the quality of the infrastructure and the quality of the images themselves is not sufficient, how are you then going to guarantee that AI will keep patients safe, never mind being effective for actual patient outcomes? So what we're offering is this three-pronged approach. It starts off with clinical radiology education. I've already shown you a lot of examples of RAD-AID teams, whether it's remote instruction or on-site instruction, teaching basic standard clinical imaging, how to interpret, how to do procedures. But then the translation of that is how to appraise AI outputs, how to supervise AI implementations. Then alongside that, the second prong is infrastructure implementation. Does it make sense to have an AI platform for head CTs if you don't even have a CT scanner? So much of the dialogue about AI, for example, neglects the fact that most of these hospitals don't even have the modality for using it. Or does it make sense if they don't have a PACS, or if they don't even have IT systems? So I've shown you before how RAD-AID has been donating CT, X-ray, ultrasound, and other modalities. And then the third prong is this phased AI introduction, making sure that there's a gradual way of introducing AI safely so people can get used to it, learn validation procedures, learn how to test it against their own interpretations so that they can figure out if there's any bias in the AI, is it accurate, et cetera. So empowering hospitals to be critical thinkers about AI is an important piece. If any of you are interested in this, there's an article RADI just published in Radiology in 2020 that really gets into the details of this. Well, let's look at that infrastructure component first. We found that a lot of institutions were very limited in their ability to even have PACS because, well, it required a climate-controlled server room, very expensive equipment. So RADI designed the RADI Friendship Cloud and the RADI Friendship Server. Here it is. It's a compact server. It fits into a small space. It's temperature resistant. And we can preload the PACS software into a little box like this and then deliver the PACS. So that's what we've been doing, replacing these large racks, climate-controlled leading type systems with something very compact. And then we integrate this server with the modalities, which are here. Then it could send images to a local client and then run backup to a cloud. Now, we've been fortunate to have a lot of supporters for this. A number of PACS companies have donated generously. The PACS software, such as Ombre Health, has done that. Google Cloud has donated cloud space. Mercury and Travelco are two companies that have helped us on the server side. So this has become RADI Friendship Cloud as a way of expediting hospitals into adopting a PACS, as well as a means for using cloud and AI, because without that, they really can't engage the advancing edge of artificial intelligence. So here's a specific example of how that all comes together. You know, here's the RAD-AID volunteer teaching basic clinical palpation for lesions. Here's ultrasound and mammogram as just an example of two modalities, clinical education. But then at the same time, here's the Kios Medical AI decision support system that can be used for characterizing whether a lesion is benign, malignant, or anything else on the BI-RADS spectrum. And by bringing it all together in this way, we can think about how clinical education infrastructure and AI do come together. Now, we've sent a lot of volunteers to do these types of projects. Our partner in some of this has been Society of Imaging and Informatics in Medicine, known as SIM. So these volunteers have gone to Nicaragua, Nigeria, Guyana, Ghana, India, Laos. So these are examples of IT specialists going with RAD-AID teams to do AI and PACS deployments. And that's how you see the kind of impact that you see here on this picture. I showed you Ghana before, but here's Nigeria. It started out like this. And by the time we were done in September of 2019, it looked like this. And this is Amina Elahi, the head of RAD-AID Informatics, sitting and doing a training with some of the personnel in Nigeria. So we received a grant to do this from Google Foundation, that's called google.org, specifically helping hospitals to appraise AI for how trustworthy it is, and also for detecting racial bias. So it comes back to that trend and theme that I described before when we were talking about women's health in the United States. What's the role of race relations? Well, AI actually has a race relations issue as well. So if you develop AI in high-income countries that are of one culture, what happens when you then implement it in a different one? Do those biases then limit performance? And how will a receiving hospital know how to validate those or detect those or even correct for those biases? So this is what RAD-AID is working on through this grant. Here's our name listed here, supporting healthcare workers as part of this grant announcement for AI. So I'm going to wrap up right here. So I've given you a lot to think about, I hope, and we can get into questions and answers now. But first of all, radiology readiness is the key. You have to think about what's already there and stick to a method that helps you to navigate what can seem so overwhelming when you first step into it. The second thing is COVID-19 did not change anything about the strategy, but it helped us learn a lot about how to implement that strategy by pivoting it and flexibly adjusting our strategies to accommodate this pandemic and be able to support hospitals in new and better ways to overcome that pandemic. And then as the pandemic recedes, which hopefully it will, as we enter 2021 with vaccines and other things now on the horizon, we will be able to pivot back into more on-site and more hybridized remote support models. Third bullet point here, race relations is intrinsic to global and local health. So if you're thinking about global health, it's not just about poverty. It's not just about whether you have the equipment. There's a lot more to it that brims under the surface, and we have to think about how racism and race relations are really intrinsic to what those outcomes are. Linked to that is also the understanding that radiology in global health is not about teaching someone to interpret an image. There's a lot more to understanding how patients are navigated, whether there's a scanner there, is the infrastructure there, and how do we really put it together? Because we're so used to thinking that all that infrastructure is already there that we may fall into the bias that it's all about teaching someone to read an image. But it's really more deep than that. And one of the reasons why I love global health so much is that the ability to really dive in and see all the different moving pieces of the radiology service model is really right there. And we need to support that. And the last is integrating AI with clinical teaching infrastructure, because we have to look at AI from a standpoint that it's not a silver bullet. It's something that has to fit in to the rest of the patterns and the rest of how the infrastructure operates. So thank you all for listening, and we can take some questions if you have some time.
We do have a couple of questions that seem to be written here, one in the chat and two in our questions and answers field. I'm happy to read those out loud if that's okay with you, Dr. Mollura.
Sure. I can actually see some of them. I can bring them down. So Daryl asks about equipment and infrastructure generally requires a lot of technically trained biomeds and IT. Are you providing that training also? Yes, definitely, because a lot of informaticists and IT specialists are very accustomed to their own types of environments. So we definitely have to train them. And we have a number of ways to do that as they get acclimated to the teams. You also asked the question, Daryl, have you standardized to a few vendors to streamline your own training processes? So RAD-AID is vendor neutral, so we try to stay away from picking one vendor, but there are several that have been very supportive, and we have worked to streamline those processes because you're right in observing that you want to make it as constant as possible and make it as streamlined as possible. So yes on the training, and we try to standardize it as much as possible while still acclimating to the local environment. The other tool set that's available to people is called the PACS Readiness Assessment, which is an extension of the Radiology Readiness Assessment. So again, that gets into the whole optimizing your solution for the local context. The second one here is from Dr. Ryu. So hi, it's great to have you on this call. Thank you so much for joining. He's got a compliment here that this is an inspiring conversation. So thank you for that. Can you talk about some of the cultural challenges that RAD-AID has faced and how they have or haven't been able to address them? Oh yeah, so that's a big topic because cultural challenges will always be there that we have to adapt to. One of the reasons why we start with that readiness assessment is because we often have to think about who the stakeholders are at the table. Sometimes it's about women's leadership. Sometimes it's about cultural etiquette. And what we do, the best solution is really to train our own personnel as much as possible in advance, to be thinking in advance of what those challenges might be. And then also being diplomatic and really trying to listen as much as possible is how we've addressed that. Because so much in global health, you want to get so much done. You go to a place and you think, oh, I just want to get in there and fix things. And sometimes you can't do that. You really have to take a step back and think, how do I listen first? And how do I think about who's at the table? and then think who's missing from this table that you thought should have been there. And that helps to address some of the cultural things that you bring up. And then Dr. Rio, you mentioned you're lucky to have Bob Harris. I completely agree. Bob's wonderful. His commitment to global health over the many years that I know him, it's just an inspiration, and RAD-AID is very lucky to have him as well. So we're looking forward to that. Another one is Hussein mentioning how does the shortage of radiology presence in the LMICs compare to that of other medical specialties? So it's a very interesting question because there are shortages in the other specialties, but now because of the way RAD-AID has organized its chapters and many of the organized strategies that we're presenting, we're actually more organized, I would argue, than any of the other specialties are, because we're using one method. We're approaching it in a systematic way. So we're catching up. It turned out, at the year 2000, about 5% of radiology programs had any global health in there, versus 50 to 60%, 70% of internal medicine, surgery, and others having a global health in their curriculum. Well, now I think we've passed them. Now with RAD-AID having 85 chapters alone out of the 130, we're now getting actually past that in how radiology is organized for global health. The other thing is you ask here, to some extent, we may see the same situation in the US with some neighborhoods such as Beverly Hills saturated, including specialized imaging centers. So exactly right, I agree with you. And that's one of the reasons why we have the RAD-AID USA program that's rapidly expanding throughout many cities and regions in the US. We have to think about global health, not just about a poor country and a high income country, but really the underserved areas as well, because there's significant shortages in a high income countries, specifically like the United States, as you've mentioned. The next one is from Bishan Desai. So thank you for the outstanding work. Well, thank you for that comment. That's very kind of you. And you say, as you implement this program for underserved, marginalized populations, are there any research opportunities? So absolutely. Lots of research, whether it's data mining, data analysis, also for outreach strategies. What's the best way to communicate the needs for radiology in a low-income region of the US? Or the research on why are the mortality rates different for different populations? Or what is the best IT strategy in parts of Africa, et cetera? There are so many research questions. So absolutely, there's a lot of research that could come out of this, and I encourage you to consider that as we develop a program with you. So Bob, is there any other questions or things we can mention or from anyone?
I don't believe so, Dan. Thank you so much for a great inspirational lecture, as usual, and we look forward to working with you in the future. And unless there are other comments, we'll wrap it up, I think.
Well, I want to thank all of you for listening. Again, I wish I could see you and be with you, but I hope to do that soon. And Bob, I'm so thankful to you for your efforts. I want everyone that, to know that we support you and your chapter. We really want to do the best for your institution and working with you to develop these programs. So thank you all for having me. Dr. Rio, thank you for your support, and we look forward to working with all of you. So have a good day, everyone. I'll talk to you soon.